Alright, today we get to remove a torus on the lower right. We'll give a little preview here, walk you through. Lenore, this is Lenore, she's excited about all the fun we're going to have today. Like I said, this is going to be the best Tuesday of this week for her. So we've actually got two tori, mandibular tori here. The right one being a little bit larger than the left side. It's creating a little bit of impingement. So we're going to create some incisions across here. Full thickness flaps as we go across. Usually I come right almost to about the midline envelope flap, typically not releasing. Then we gently remove the tissue full thickness flap over the top, section through to remove those with the 702 burr typically. Remove those sections, smooth everything down real nice, and then we're going to put some stitches in here. Now the stitches that we're going to put in are going to be the 4O stitches. Actually, let's do 3O stitches. Go ahead and put those into the water. 4Os would work just fine. They're a little bit smaller, but the needle driver has a smaller segment to it, so the 3Os will be a little bit easier to get through those papillae or those embrasures there. So, and that is the plan. I'm just going to verify anesthetic here. Okay, does that feel sharp? Okay. Does that feel sharp? Does that feel sharp there? Great. Okay. Does that feel sharp there? Okay. And does that feel sharp there? Okay, good. Okay. And I'm going to go and put in an oftrigate as well, just to give us a little easier visualization. I'm going to grab just a regular oftrigate. Open for me just a little bit. Thank you, Haley.
Thank you.
This is a little bit of a retractor of the lips here. Okay. And there we go. Okay, turn to the right just a little bit. Great. Chin. Go ahead and hold the chin right there. Lift your chin up just a little bit. Okay. Just gentle pressure right there, just to resist my pressing down. As I start, the reflection, you see, is the curve that follows the tube. And as we get a little lower, I flip it around so we get a little bit more leverage. Lenore's got nice, good, strong keratinized tissue here. It's not always this nice and resilient. Chin support, resist that pressing down there. As I kind of push down, you just resist that healing. Good job. So especially as we get into this is a little bit more like mucosa, so we got to be just gentle, take our time, make sure, again, full thickness. We're putting quite a bit of pressure against the osseous to make sure we're getting, oh, pinchy there? Okay. Good to know. Keep the suction in there. That's still your job. Yeah, just hold it. Just keep the suction in there. Getting right across that midline, so that's normal. If we're getting tiptoeing across that midline, that block on the right doesn't quite get all the way over there. So. We'll come back to this one here. And just gently, again, full thickness flap lifting. We want to keep that all full thickness intact. Back up a little bit. Enough of an envelope flap to make sure of a nice transition. Able to access without stressing out the tissue very much. Right up to the midline here. That's all just cortical bone there. There's no medullary bone generally in those areas. So we've got those two main tori there as well as that little guy there. So we're actually doing all three of those guys. Okay, good. Hand switcheroo here. And protect the flap. And just water. Vibration. And one thing that's tricky is we want to trim basically straight down. We also want to flute away a little bit, but it's also the jaw kind of dives in more to the facial as well. So as a general rule, I take just mostly a fairly straight down approach, and then we make any adjustments once we get full release. The other thing we're careful about is the flap on the bottom side of this needs to make sure that we have that released as well. If I can't make sure it's released really well, I don't want to cut through and get into the soft tissue because that can traumatize the soft tissue. And we want to minimize that because then the healing will be more comfortable. So when in doubt, just like a tooth, section it into a smaller piece. Try to escape. Suction right here. Yep, all the way up and down. Good. angle can be a little tricky to access there, so I'm just going to test to see if that's enough to move on. Not quite, so I'll rotate that and that'll give us some flexion once we've gotten to the base of the bone there. I never know exactly how that lower section is attached. Just take our time. We'll get a hard time accessing lower. We're going to just section out a piece. So I'm going to go ahead and section this guy out here. There, Doc. Lenore knows you're coming in for a little look.
Hi, you're doing, sir.
Okay. So I already did the flap. I've removed two of the smaller tori. The larger tori did section this way, now section through. And then I got a little bit of release on this front side here. So we're taking this out. Very similar, just removing a wisdom tooth. Okay. And then test this back side here. Get a little flexion. There it goes. So a little bit more attachment there, and you can see our before there. So I would say the two most critical things that I think of when I'm removing these are, number one, a real clean, careful flap. Because if your flap gets ragged, the healing is more difficult if that happens. So nice full thickness flap, gentle and careful removal. The second is the bone that we have behind, that we leave behind, we want to make sure is nice and smooth, a smooth transition. So as it is right now, we've removed the bulk of the tori, but right here we still have kind of that ledge. So I need to smooth that down without traumatizing the tissue underneath it. So we're continuing here with the full thickness flap and kind of just adjusting and reflecting that back here. Now I'm going to polish the rest of that bone away there, and then I'm going to switch to a different burr that's going to help me smooth it down a little bit easier. This burr is doesn't create the prettiest finish. It's excellent at bulk reduction, but it's not as easy to do the fine tuning finishing. And you'll notice that I keep that periosteal. You can also use from the osseous kit, you can use an Allen retractor. It's a little bit different. It's a little bigger and flatter. Fortunately, this one's pretty simple, so I'm not stressing that too much because I've got good access. I don't need anything more fancy. So there's two different things I can now take on the osseous. So in this one, my friend, is going to be the fat black diamond because it's got nice, smooth, rounded edges, gives nice, smooth transitions. It's a little on the shorter side, but Dr. Ochoa knows all about that. So she can handle stuff a little bit on the shorter side. And okay, so all this bone all across here, we're 90% reduced. So all this bone here, I'm just going to make sure it's nice, smooth transitions. Right now, it's just a little bit ragged. So we're going to polish it all down nice and smooth. It's got that broad, round end to it. The black diamond does. It makes a nice, smooth, not smooth like red diamond, but nice, smooth for bone finish. You just don't want any sharp corners or edges. Nice, smooth transitions. Don't want to catch those flaps there at all, so we keep the periosteal or the underwoman in between the burr and the flap, always protecting it.
Doctor, you have a sticky nose.
Okay. Is it urgent that I need to know right now?
Patient ready enough now.
That wasn't my question. It was a yes or no question. Is it urgent that I need to know right now?
Not urgent.
The answer is no, doctor. So try that. No, doctor.
No, doctor.
Okay, there we go. We're getting that nice smooth transition around this lower edge. We don't want a spine there because then the gums will be irritated from that. That can create a sore spot in the gums. Just keep that suction right there here. And great more. And turn to right just a little bit more than that. And it's better to have the flap a little bit lower so that there's less trauma suction. Then to keep it a little bit higher and then nick or abrade the flap, because then that causes bleeding that is unnecessary to cause that. Okay. Last little bit of shaping here. Tori do like to recur if there's continued grinding, so just going to remove any little bit, but Gives us a head start on the next one. And Haley's doing a great job managing all that water that's coming off this guy. A little bit of some fluting and transition here. No ledges, everything smooth, rounded, no corners. Okay, you can see that finish now, nice smooth border across the lower there, transition to down lower in, smooth transition up here across the top, nice little indent there. And that'll do it. Now we irrigate, let's do 4 full syringes, saliva ejector. We just want to get bone dust out of here, that's all. We always start at the top and rinse down. It's counterproductive to start at the bottom and rinse up, because then you're re-rinsing over. Lots to be worked on. Did you put the 3-0 into the water?
Yeah.
Oh, okay. You just took it out for me.
Yeah, just for you guys.
Thank you. Appreciate that. Delicious. We're going to do a little bit of a double sling style, and I'm actually going to come from the outside. If we tie on the inside next to the tongue is not a big fan of having a tie on the lingual. There's lots of ways that this can be done. It can be done with multiple interrupteds. I'm just going to do a double sling here. We sling around this tooth here to get the next one. And we do a double sling because I don't like to just tie off on one end. I like to tie off the ends together. Just 4 out of 10 pressure, like most stitches. Just a 4 out of 10 tug on that. And because of that turnaround. They're having a little more friction than I was expecting. I'm going to pull it tight before I feed back through. These stitches will fall out on their own in a week, give or take, Lenore. We're welcome to start brushing on the gums as soon as they fall out. Some people, they fall in 4 days. Other people, it's almost up to 2 weeks. Don't stress that. It'll just come out when they're ready. So now it's just a matter of getting back to the tie. So this one I'm not going to sling each one. I'm actually just going to thread through and around. I'm just kind of threading through every other one. I don't need every single one in there. Okay. Bring it out. And double throw on that. No pressure there. Back throw. And final forward throw. Okay, so it actually looks like the tori is still there, but that's just the residual fluid that wants to kind of sit in that area. So now we can see that tori is completely gone. Okay, and I'm going to put a little bit of pressure in that area with some cotton. Little gauze here. Just going to moisten it a bit. I'm just going to put some digital pressure here. Okay, turn to the left a little bit more then. Good. Okay. So I'm just squeezing against that, just holding the flap real nice and tight against. Then we're going to take a final photo. Go ahead and get ready for a photo there, Haley. And open form just a little bit there. Good. Okay, go ahead and save that. Show and compare. There you go, boom. It's like magic. So, common errors are not being careful enough or unable to reflect a nice full thickness flap without any tears in it. Sometimes when they're really big, it's almost impossible to not get a little tear, especially if the tissue is nice and thin or that kind of stuff, or it's too thin. Another thing is not getting the flap low enough below, and when you go to adjust that bottom edge of the transition from the very bottom edge of the torus to the rest of the lingual side of the mandible as it goes lower, and you irritate or catch the flap there, and that causes some bleeding and unnecessary additional inflammation. Not reducing enough bone is another possible downside. Yeah, those are the main ones. And then patient expectation, the big one. So I told them more. It's going to be super annoying here for about 2 weeks, and hopefully that will be it. Maybe she might get a pleasant surprise that takes less time to settle down than that. So. Okay, so you got ibuprofen and Tylenol for the next few days. I'd recommend taking the first 24 hours, and then after that